Well, this is quite a follow-up to be after all of these giants in our field, and I'm thrilled to be here, and I thank you very much for having me. And my slides are not going to have that nice MGH and MGH, no, Beth Israel. Sorry, the fancy slides. Anyways, but they are hopefully interesting for you. Okay, well. There's been a lot of fascinating information this weekend. A lot of it's been maybe stuff that we don't always have the opportunity to work with because these patients are, maybe taking that next step to have some surgical procedure. And I'm going to talk about, well, what do we do getting these patients ready for these surgical procedures, or how do we maximize the patient's opportunity, once we've done our MLD, and hopefully come up with some different ideas for you to think about in terms of saving yourselves as therapists, saving your hands as therapists. And so we'll get going. So yes, this is really a patient that came into my clinic, by the way. Sometimes patients can get very creative with trying to do things with their garments that aren't fitting very well. So, by the way, now, that was a couple of years ago. She's doing great. She wears 2 stockings, and her foot never doesn't look like that anymore. So that's the good part. Okay. So disclosures. I want to spend just a minute on disclosures. And the reason I want to spend a minute on disclosures is because I am very fortunate to be able to wander around the country and talk to a lot of people, and I'm thrilled that I am offered the opportunity to speak for some of these companies, and I'm so impressed with them because they always let me come in and talk about the problem. They always let me talk about all of the different parts of the problem and all of the different things that we would use to solve a problem. And without all of these companies, we wouldn't be able to do our jobs. So I would like to, give a big hello and thank you for being here and helping us to manage our patients. I also had the opportunity to work for Tufts and create a lymphedema program for the DPT students. Garments, scratch your head. What are the differences? What do we do? Which garments are appropriate? How do we choose one over the others? Well, that's one of the wonderful things about all these companies out there is that they've created lots of different types of garments, and they all have a little different slant to them, and they're all trying really hard to meet the needs of our patients or meet the needs that we have as therapists. And we go to them and we say, this is what we need, and they're trying to help us with that, and so that's very appreciated. So what are the compression options that we have? Well, we have daytime, nighttime, Velcros, over-the-counters, customs, textured, and then we do combinations of garments. And they're appropriate for lots of different reasons. So in my experience, the clinical observations that I have is that we have the ability to improve the lymph system's tissues capacity in the long term by supporting the tissues and improving their valvular function with compression. But the body's always trying to restore that homeostasis, so fluid goes everywhere it can. And patients do participate in self-care, and they try really, really hard, and it's really our job to give them the most appropriate opportunity that we can to help them to manage their lymphedema. But the thing is that they need to see results, and it needs to be in such a way that they can manage it, because our patients come in with lots of different limitations or ideas or even what they're willing to do. And so my mantra at my work is the least amount of work to stay the same. So what are we going to do to help that patient get to that point? We also have to help them with a plan that they can actually live with. So what's our dilemma? Well, number one, there's this optimal portion out there. The gold standard is 2 to 4 weeks of lymphedema therapy with MLD and good bandaging. It would be wonderful if they all came in with a fabulous diet and lifestyle. Help from a caregiver if they would happen to need it, and the ability of us to provide any over-the-counter or any custom or any product that that patient needs, and boom, it would be there in our clinic, and we would be able to give it to the patient, and everything would go very smoothly. And then, of course, compliance would be awesome too. So how many of us, raise your hand if all your patients come in with those opportunities? Okay. So the reality is that we have less and less time to treat these patients. They have less number of treatments that they can have access to depending on their insurance. A lot of them have unhealthy skin. They have financial limitations. There's not enough lymphedema therapists around, and the patients need to achieve the compliance, and that's often a real challenge for them. So when we treat lymphatics, we've heard this over and over during this conference, that we need to really respect and adhere to the real principles of complete decongestive therapy. And that is that, skimping on helping that decongestive process happen and helping those patients get to the point through probably bandaging or some other component, but really getting that patient's limb down to a level that the compression garment's going to be able to do their job. And we're all challenged with that for all of the reasons that we just saw on the last slide. But what happens when the patient can't do it? They just can't tolerate a traditional approach. Or what if they're just not willing to buy in? I mean, how many patients do we have that come in that just say, I'm never going to wear that garment? And what if they have more than one complication? And that's been really wonderful here to understand and hear about the different disciplines that work with the patients that have the opportunity to come into this facility. And I know that myself out in a private practice, I don't always have that opportunity. So I'm making phone calls to lots of people to try to figure out what else should we look at and where can I send that patient for more information. But then I came up with some rules, and I said, number one, because does anybody ever feel like they're occasionally a dumping ground? Like the patients that walk in, you scratch your head and you think, oh my goodness, how am I going to get through this one? Or the patients really just want to come in and drop their bodies off and pick them up later. Do you ever have those patients? Drop their body off, pick it up later, and then be able to, have it all fixed when they pick it up. That would be great, right? Like a car. But that doesn't always happen, and the patients really have to be able to take an active role in what they're trying to do. So my number one rule is I'm not going to work harder than the patient's willing to work for themselves. So, that's a really big deal. I mean, I talk to therapists across the country on a regular basis, and they are, busting their humps trying to help these patients make it through and get them better, but the patients just aren't doing as much as they could for themselves. So I think that's the number one rule. My next rule is some is usually better than none. So that doesn't mean that we want to compromise what we're giving them, but we also have to be a little bit respectful about what that patient's actually willing to do. And so there will be times when maybe I would want to dive right into the decongestive process and the bandaging process, but maybe that patient's just not there. And so I might just start with some other treatments that I can do just to start to decongest them. Or if they're so congested up to their waist, you can't just, sometimes they're just not in a position to dive right in and bandage them all the way up. Or put garments all the way up to their waist. Sometimes they're just not mentally ready to do that. So sometimes I'll have patients come in and I'll work with them and I'll give them one or two things, or I'll start with a pump and just let them decongest with a pump for a couple of visits or a little bit of time and allow them to make this change a little bit slower. And then the third one is education, 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 and then more patients. Because I think that everybody deserves the opportunity to move forward as they can, and they all come in with a different psychological perspective, and they all need to be able to get to that place in time where they're going to be successful. And then there's always those patients that you just look at them and you say, this is just not something that's going to work right now. And that's actually okay to say. And so I hope you all, when you get those patients that come in like that, it's okay to say to them that now maybe isn't the time for us to initiate. Here's some things that you can do. I've had patients that have come in like that, and all I do is give them a Velcro garment. And I say, why don't you try wearing this for a little while, a little bit of compression. Maybe this will be more comfortable, and then let's talk in a month. So, being able to look at what that patient's willing to do. So our responsibilities as lymphedema therapists are to give them a toolbox. And I like to think about giving my patients lots and lots of options to be able to manage this, because this is a chronic condition. It's probably not going to go away. And if someone said to me, this is the only pair of shoes you get for the rest of your life, I would be sad. I couldn't live like that. So they need different tools, and they need different opportunities. If they're going to be at a wedding and they want to wear a thin garment with a nice pair of shoes or a dress or something like that, it's okay to have a garment that is thinner, or maybe none at all for that day. Maybe we teach them how to prepare for that. Maybe they do a lot of preparation up to it, then the day comes, they get to wear whatever they want to wear, and then afterwards they know it's going to be maybe a little bit challenging, and then they get to have another strategy afterwards to be able to manage that. If they understand the capacity to use those compression garments to their advantage, it's really helpful. But other things they need to have is the flexibility. Does that patient have the flexibility to get on a flat knit custom garment? You know, can they manage Velcro? Velcro's kind of stiff sometimes, and there's a lot of patients who have arthritis that can't manage Velcro. So do they have someone to help them at home? And what are they willing to do? I had a patient come in last week who he sat down at in my office, and I said, "Hi, what can I do for you today?" He says, "Well, I don't know why I'm here." And I said, "Oh, okay. Well, your diagnosis is lymphedema. Do you have lymphedema?" He says, "No." I said, okay. So, you know, what are they willing to do? And then what sort of support system do they have at home? That's a really important thing. The other thing I'd say at my clinic is that this is a no-guilt zone. I am never going to look at a patient and say, well, you should have been wearing these garments, or look what happened to you, you increased. I think we should expect that they're going to. This is a lifelong condition, and everybody takes their birthday off. So and they know there's going to be a ramification, and I don't need to be that person someone said earlier in the conference, you know, I don't take their lymphedema home with me. So that's lucky for us that we don't have to do that for our patients. But being able to remove that guilt factor from them and help them be a problem solver, I think is really a big role that we have. So when a patient comes in and they're hanging their head low and they say, no, I haven't been doing what I should have been doing, I say, well, tomorrow's a new day, and we're going to pick it up from here, and let's look at what worked and what didn't work and see if we can't make that work for you. So in the olden days, this was the only book that we used to have. Does everybody remember the green book? But they talked about the key points of medical stockings, and you know, these are the reasons that we use them. If there's an abnormally increased ultrafiltration, it helps us to improve resorption. It helps the joints and muscle pumps to be more effective, and it reduces fibrosis and sclerosis of the skin. And these bigger problems really do better with a stiffer type of a garment, which is usually the flat knit. So inflammation, I was really excited to hear the physician earlier talk a little bit about inflammation, because I think inflammation is something we need to pay attention to. Inflammation makes our job harder, it makes our patients' jobs harder, and it was interesting to hear that the lymphatic fluid is the thing that really causes the major inflammatory process in our system. Because if we could manage that better, I think our patients' garments would fit better, and they would their size would go down. So that would be really, really helpful. But it's clear from both experimental and clinical studies that inflammation is a critical player in the pathophysiology of lymphedema. And it's not just confined to the dermis. It's been detected in the subcutaneous tissue and in the adipose tissue. And it's due to that fat deposition, as we heard a little bit earlier. And when fibrosis is inhibited, lymphatic vessel repair and transport are improved, and it slows down the progression of lymphedema. So I think of this a little bit like salt and water, or a little bit like a sponge. And when that fibrosis or that pitting edema or that fluid's been sitting around for a long time, it just calls in that fluid, sits around there longer, and it goes from liquid jello to firm jello. And then it's just harder for us to move that out. So if we're wanting the garments to fit better, then if we pay more attention to the pitting edema and the fibrosis and really try to maximize what that patient's moving out, that's really, really helpful. So the key concept in fibrosis is this inflammatory process. And lymphostasis alone cannot account for the destructive tissue tissue injury associated with lymphedema. And then Dr. Roxon says inflammation and fibrosis are intertwined. So we've heard that before. And this is a picture of one of my patients who I'm going to talk about how I got that pattern on her arm, and maybe a little different spin on how to approach initial decongestion. So pitting edema and fibrosis, I don't need to tell everybody about this because I'm preaching to the choir here a little bit, but we struggle. We struggle with how to get these patients down. Look at how the garment fit was on this guy's right leg, or his left leg. I mean, you can see that tourniquet effect around his leg. And we've been using foam for a long time, and we use foam in lots of different places, and we use it in different textures and different shapes. And foam can be really, really helpful in helping us increase and decrease pressures and move fluid through channels that are created by these high and low pressure areas. But pitting edema and fibrosis reduction will help with the bandaging and the compression and the garment fit. So optimal bandaging pressures. Well, less than 20 millimeters has been thought of as sort of mild. 20 to 40 is medium, 40 to 60 is strong. But one thing that's interesting is when we put those bandages on that patient, how many of them fall off within the first half an hour, or they're falling down. And so then we try to get creative with how we put those bandages on so that the patient might be able to snug that up with one layer or so that they don't lose the efficacy of that bandage. The recommendations are to aim for about 50 millimeters of pressure when we're putting it on. Now, down at the bottom picture, you'll see that nice color. And I have decided to use polar fleece underneath my bandages. And I use polar fleece because cast padding tends to get thin and flat. And it doesn't really give the amount of bulk that I want to disperse the pressure of the bandages I'm putting it on. And it's also cheap and it's washable. And I've also found that with patients, sometimes when their skin is impaired and I put the stockinette on their leg, that stockinette can be kind of abrasive sometimes because if it's really tight and their skin's really thin, that's tough, and I don't want to compromise the skin in any way. So as a seamstress, and I was a design major before I was a physical therapist, so I really love fabric a lot, and I love the qualities of fabric a lot, and I'm a quilter. I started thinking about what else could I use on this patient's leg, because and sometimes I would have patients come in and I didn't have the right size of stockinette. Has that ever happened to you? The supplies are just down for some reason. And so what am I going to be able to put on this patient's leg to disperse the pressure of that bandage and give that semi-rigid cast? So a patient can go to some fabric store and they can buy for about $5 a yard of this stuff, cut it into the strips that are the size that they need, and put that under the bandage and then wash it and wash it and wash it. So I, in a lot of cases, don't even put stockinette underneath this. And patients really don't complain about it being too hot. It's not any hotter than having cast padding and different other layers that are on for the bandaging process. And it's pretty comfortable. So that's one of my little tricks and tips that I use in my clinic to help my patients. So another thing that I've been doing in my clinic is using pneumatic compression with foam, channel foam at the very beginning. So this is my patient, Stephen, and we'll talk about him in the breakout sessions a little bit more. Is that okay. This is when he came in. Now, what I want you to notice is the shape of the bottom of his foot. His foot is so swollen, his ankle is tremendously swollen, and his toes hardly don't move. There's his pitting, which was terrible. And we were able to, in 2 days of treatment, reduce the amount of fluid in his legs by 1,000 mLs in each leg. That's a huge amount of change. And I have to tell you how I came about doing this. I had a patient who called me one day from Maine, and this was many, many years ago, probably 10 years ago, called me from Maine, and she said, I'm calling because I have a really lymphedematous arm and I'd like to have it amputated. We don't do that, by the way. And I'm wondering if a laser will help, because she knew I had a laser. And I was like, why don't you tell me a little bit more about this? So she tells me that she's been through complex decongestive therapy and that she's not able to work as a bookkeeper anymore because she doesn't have finger dexterity, and she just has a lump of an arm and she can't use it at all. And I said, well, I don't think a laser is your answer for this. And I do all of the things that it sounds like you've had in the process of decongestive therapy, and I don't know what to tell you. You live in Maine, which is a 9-hour drive from her house, was a 9-hour drive from my house. And I said, if you'd like to come to Vermont sometime, I'd be happy to give you a second opinion. Didn't think about it again. 4 months later, I walk into the treatment room, and there she is, and she says, I've taken out a loan to come see you. Pressure. And she says, and I'm here for 5 days. So I took a deep breath and I measured her arm, and it was a 9-centimeter difference between one arm and the other arm. What am I going to do in 5 days that's going to be meaningful to somebody and have them come away after taking out a loan and staying in a hotel? I almost wanted to take her home and I say, honey, you don't have to pay for the hotel. Anyways, so I started looking around my clinic like, well, what can I do to make some meaningful change for this patient? And I have, up until that time, been doing the traditional MLD, just, lots of rubbing, but she was very, as you can imagine, very fibrotic. Well, I know there's, pitting and fibrosis are sort of on a continuum, and you can have both. And she had quite a bit of pitting, but she was also just very, very hard because it had been many, many years. Well, I had been using a product, oops, that's the wrong one, that I made that looks like this. So what I did was I had a patient who had a lot of fatty infiltrate and a lot of fluid in her arm, and her arm was incredibly heavy, and I just couldn't get it out with bandaging. I couldn't get it out with pressure. And so I called one of my friends, and she says, well, go get a Comprex 2 sheet and cut it into pieces, sew it together, and wrap that up on her arm, and then bandage over the top of that. So I had been doing that for a patient. That was the only way we could manage her, about twice a week. She had to do that. She also had pumps, she also had a night garment, and she also had flat neck garments. But we just couldn't get the fluid out of that arm because of the fatty infiltrate, and it would just increase the weight of her arm. So I had this jelly roll, I call them jelly rolls, sitting around. So I said, okay, well, what happens if I put this underneath my pump for that patient who had taken out the loan to come see me? And in 2 days, we got out about 2 centimeters of swelling in 2 days in her arm. Her arm felt lighter. And I had pumped her for about 30 to 45 minutes before I treated her. Then I did my MLD. We cleared her lymph nodes first, and it made a huge difference. And so at the end of the 3rd day that patient from Maine was visiting me, she had gone down 3 of the 6 centimeters. Well, I had never taken anybody down 3 centimeters in 3 days, ever. And so that made me really scratch my head and start thinking about how we're mobilizing fluid. And by the 3rd day, I had made some phone calls, and I had gotten a reed sleeve. Back then we had reed sleeves, and that was something that was going to be adjustable for her, because I knew she wasn't ready to go into any type of garment. So I spent a long time educating her on how to do MLD, how to use her the adjustable garment, and how her husband could help her with this. And off she went in 5 days, feeling pretty happy, believe it or not, that 3 centimeters had come down and her arm felt quite a bit better. And then about 4 months later, I walk into my treatment room, and there she is again. She says, I've taken out another loan, and I'm here to see you for 3 days. I said, oh, 3 days. So anyways, I went ahead and I remeasured her, and she had on her own taken her arm down another 2 centimeters. So now we've got a 5 centimeter difference in a total number of treatments that I've seen her really only in 5, because she came in with that 2 centimeter reduction. So now she's 5 centimeters out of 9 centimeters, which is, a little more than 50%, but that's about where you get to in a lot of these patients when you're first starting to treat them. So after that, I started really thinking about how hard I was working to mobilize fluid, and I started using the pumps that I had in my clinic. So anyways, I used this process of making the jelly roll right here, putting it under a pump. So when I have a patient who comes in with a lot of pitting and a lot of fibrosis, this is what I do for them. And I might do this on day 1. Now I realize that this is not terribly novel, because we've all been using foam for a long time, and we use foam under pressure, and we use foam under pumps, and we use different kinds of chipped foam under pumps and stuff like that. But the point here is that I'm suggesting that maybe we could actually use this on the first day that we see patients for treatment. And maybe we could get them through the bandaging process more efficiently, because the other thing that I see by doing this is that their bandages stay up better, because I'm mobilizing quite a bit of fluid in that first day. And that might be really helpful for patients. And most of the time, if I have a moderate stage 2 patient, I can get them into garments in like 2 weeks or less. So that's pretty good compared to what our limitations are from insurance and patients' ability. So that's one of the things that I do. The other thing is that the reason I like this is because it's adjustable to every size leg. I mean, there are a lot of products that we'll see later on in my presentation that are out there, and companies have done a great job at making different custom products or different sized products, but I can't get those on day 1. And I may use those later on for the patient depending on what they need for self-management. But on day 1, this fits everybody, and I can wash it and dry it 1,000 times. So why use pneumatic compression? Maybe reduce the time and then maybe the number of treatments that you're going to need, decrease the pitting edema, and soften the fibrosis. Patients are amazed at how soft their limbs are after we do this process. It stretches the skin. So if we think about when we use flat compression, we're not actually increasing the length of the skin, and that's what we have to do to stretch that fibrosis. You actually have to get into the plastic range. So when a patient comes out with the arm looking like that, and they've got that corrugated look to it, we know that we've actually stretched the skin. And then there's the patients that walk in like this lady right here. So obviously her garments aren't working very well for her. And that's a picture of my hand up there, because I happen to be an older therapist, and I happen to have used my hands for 25 years of lymphatic treatment, and I've blown the ligaments in my fingers, and I hold up my finger all the time, and I say, this is my career crusher, because this hand of mine just can't do the sideways treatment. It can't do the deep pressure. And at the NLN, they went over many times, and then our Australian team has told us too, it requires a lot of deep, slow pressure to actually move this stuff through the tissues. And so we need to have need the ability and the strength to apply that and make those changes. And some of us, I can't put that much pressure in certain positions through my fingers anymore. But this is also a really efficient way to do it. So this is how I make the jelly roll, and I won't keep that very long. It's pretty simple. I cut it into 5 pieces. I can only fit 3 in the picture here, and then I flat sew it together, and then it comes out as a roll, and then we end up putting on the patients. So I actually make these for my patients if that's appropriate for them. If some of them would prefer to have one that slides on their leg, if they're going to use a pump as a home management tool, I can do that too. So it just depends on what the patient needs. So here's a couple of options. So I tried the Comprex 2 and I tried the Mobiderm. I got good pressure from both of them. Probably the difference for me would be that the Mobiderm is in tape, so that might be more of a short-term solution or a solution that maybe only one patient's going to use. But because I use it on lots of patients and we wash these on a regular basis, I tend to use the Comprex 2 because we wash them and dry them in our dryer. We do always cover the patient's limb. I didn't in this case because I was taking pictures, but we do always cover the patient's limb with a pillowcase, or we have them wear pants, like pajama pants or some kind of thin athletic pants or something like that. So we generally put, even though we do wash them, we put them over that. So we could accelerate the reduction phase. I use it for a pre-treatment. For manual therapy, so this is not taking away from the principles of complete decongestive therapy and anything else that I can do, but it shortens the amount of time that I have to spend just moving fluid. And as the fluid comes down, I always tell my patients the rocks start to show, and then we get to see where is the real congestion happening. Where do we need to spend time on fibrosis? Where might I want to laser? What part can I focus on to help them get better movement of fluid through their tissues? I do start with pressures of about 50 millimeters of pressure and avoid constriction with anything that I've got underneath it. So what are the styles of compression garments? There's lots of options out there. It depends on the site, the extent, the shape, distortion, severity. And then what is that patient willing to do, and what can they do, and what kind of support do they have at home? And a big point that I would really like to make, that we are very empathic. We are an empathic group of people, and we are always caring about what our patients can and can't do. We all feel a little guilty, I think, that everything in healthcare has become so expensive, and the amount of stuff that's required for patients to manage lymphedema is enormous. And depending on their insurance, especially, well, we've got the Lymphedema Treatment Act, and we hope that that's very helpful next year. But the amount of stuff that they need, and if we're looking at the concept of a toolbox, it's a lot of stuff that could go in that toolbox. But one point that I'd really like to make to all of us is that it is really not our responsibility to choose what that patient can afford. Okay, I had a little lady come in one day, and I really wanted to get her a chipped foam sleeve right offhand because she had a terrible, terrible pitting problem. And I said to her, and she looked like a lady of not a lot of means, right? And I said, well, here's what I think you need, and I know that it's expensive, but I think you would get to your end result much quicker if we could start treatment this way. And she says, that's okay. My daughter said she would help me. And I said, well, that's really nice. Where does your daughter live? And she says, California. I said, oh, really? What does she do out there? And she says, have you ever heard of the show Wicked? I said, yes. She says, my daughter wrote it. So, again, we cannot judge our patients. So I think our responsibilities as medical professionals is to tell the patient what is the best product for them, whatever it is, whatever the cost. And then if that doesn't work for a patient, then we can start to make changes. But we don't want to go to our surgeon and have them make a decision as to what surgery they're going to give us because of what we can or cannot afford, right? So I really want to make that point that our job as professionals, they are paying a lot of money for our services and for our expertise, and our job is to really tell them what products are going to make their life easier, and then we can pare down from there. So there's a little bit of difference between circular knits and the flat knits, and I'm not going to spend too much time on that, but those are the standards that are out there. So circular knit versus a flat knit. So I call the difference between circular knits and flat knits are squeezy compression versus container compression. So a container compression is more like a vase of flowers. You're going to put water in that vase and it's not going to expand, it's going to be the same. And then there's a water balloon. Then you can put water into the water balloon and that just keeps growing and growing and growing, but the pressure gets greater and greater and greater. And depending on the shape of the limb, that garment has the opportunity to migrate, and that's a real problem for a lot of our patients. So really the circular knits are for weddings, they're for milder patients, but that doesn't mean that a patient that has moderate swelling can't have one of those too. So I call the flat knits the workhorses, and I will often have a patient get a workhorse, and that's part of what they use, and then they can have a circular knit also for when they're maybe not wanting to have the bulk or they just need a difference. I mean, just like having a different pair of shoes, sometimes it's just nice to have a change. So this is just a little graph that talks about size tolerance, and you can just see that there's a really steep curve right here because it doesn't take very long for the flat knit to get to the end of its ability to stretch. And that's one of the properties that we really love about flat knit fabrics. But when we look at a circular knit, it takes a long time, but it stretches a lot, but it'll get right up to that point, but there's all of this in between. And that just makes it's just more squeezy for them. So in a circular knit garment, being a person who loves fabric, it's basically one continuous lycra thread that's spun all the way up to the top that's why it's called circular knit. And it's good for a lot of reasons. But it doesn't help with the law of Laplace, helps it makes it migrate just a bit. And if we look at the fabric, the way the circular knit fabric is, that the inside and the outside of the knitted fabric don't actually have the same amount of tension, and that's what makes them curl, and that's what makes them migrate. So that they tend to curl when they're cut, so that's why it's made in one particular piece. But when we look at a flat knit fabric, you can see those stitches up there are even, and that is actually the pattern of a flat knit. So the companies will knit in the actual size changes for that patient, and then it's sewed together to accommodate for whatever shape or bulge or position that they need that to be in. And it's really awesome. So there's a lot of stage 1 patients that I will actually give them a flat knit too, especially if they have a lot of fibrosis. So again, thinking about what does that patient need, and just because there may be a stage 1 or a 1.5 or a 2- or whatever we want to think about, really consider the properties that patient that patient has, and what's going to help them manage this. So then there's the inelastic garments, which are really helpful for a lot of things, and I think they've saved all of us in a time or two with several different types of patients. And all the companies are making them now, and we appreciate that we have these options, and they all maybe have a little different specific to them. But I think they've been a real help. And sometimes I'll have a patient have a flat knit, a circular knit, and an inelastic garment, a Velcro garment. And that way they get to choose. And I say, what kind of day is it today? Giving these patients an opportunity and teaching them in advance how, when this gets out of hand, they're going to get it back down again is really helpful. One of the beauties for the inelastic garments or the Velcro garments is that they have such a grace period in terms of you can tighten them up, you can loosen them up. If you've got patients that do high fluctuations of sizing, the flat knit garments only go about 1 centimeter on either side, and then they don't fit the patient anymore. The circular knits are a little bit better, but then they roll around. But when we use these Velcro garments, that patient has a little more opportunity to maybe cinch that up and get back down to the size that they're trying to get to. And sometimes, like I said earlier, I'll use this in the reduction phase for certain patients. And what do you do when your horse gets lymphedema of the leg? This is actually a ferro wrap on a horse in Australia. So when I was lecturing in Australia for Job's Essity, one of the people I was working with, she had this picture, and it's one of my favorites. So it works for lots of different things. Textured garments. How many of you are using textured things out there? Texture is the bomb. Texture is so helpful, and we've got different companies that are making. Juzo just has one out there that, take a look at that one. They have a new one. But texture is wonderful. I've been known to take these garments and cut them up and stick them in bras or, put them over ankles or whatever. But being able to have texture available to us is making a big difference in our patients. And it creates that corrugation that I get with the channel foam. So it depends on what area you need. I really like the ones that have 2 arms because I have a few patients who are aesthetically, it's just nice for them to have 2 arms that are the same if they're going out. So that's an option. But they also might have a flat knit garment at home that's going to contain them. So the night garments. Night garments, I think, are great. I know that when I was lecturing in Europe a few years ago, that was a new concept for them. They weren't using a lot of night garments in Europe. And so I asked them, well, what are you doing when the patients get bigger at night? Sort of like you were saying earlier, the patients get bigger at night, that is just harder for them to manage the next day. But I think with the night garments, they are really, really helpful back to those patients who have a lot of pitting and a lot of fibrosis. I don't know that it works on the puffy quite as well, but it's really good for the fibrosis and pitting. And we like those. The expected outcome is obviously the texture on the arm. And then just being creative with all sorts of different foams. And I have lots of different things at my clinic that I play with, and I want to give everybody permission to really think about using these things and look at your patient's problem and try to think about what of these products will help them. Gloves, always a challenge. I think probably one of the biggest things for gloves is to really go through with your manufacturer and learn how to fit them, because that can make all the difference in the world, the way you fit the glove and the way you hold the tape measure and where you measure. So please think about that when you're ordering a custom glove for your patients, because gloves need to be comfortable for patients or they're not going to wear them. Up at the top there, you'll see some tape, some pink tape. That's actually a picture from a speech-language pathologist named Brad Smith, who does work with neuropathy. And I threw those in there just for fun because I like to throw in a little pearl every now and then. It's just one way to try to change neuropathies in hands is to use tape. And I use this on legs too, when the patients have sensory changes after chemotherapy. And I don't think I'm fixing anything, but what I'm doing is I'm calling in another one of their sensory systems. So, and I've had patients who I put tape on their leg, and I go down the front of their leg, make little toe holes for them, and then it goes back up their leg, and walk out of my clinic saying, I can feel my feet now. And I think I didn't do anything magic except for that I turned on another sensory system, and the change in the tape pressure is helping that patient proprioceptively know where they are in space. So let's think about, it's not just for swelling. It's also going to improve that patient's proprioception and where they are. And if they can use their fingers better, feel their fingers better, that's going to be really helpful. It also helps with swelling, of course. We know that. But think about the use of tape in terms of turning on another sensory organ for patients to be able to know where they are. Also, talk to your manufacturers and try to get samples in your clinic, because if you could have a little box of gloves and be able to sort of let patients try them on, it makes a big difference. Oh, near and dear to my heart, trunk compression. So I developed the Belize bra in 1999, and I did that because of frustration. I got out of my training with Gunther Close and Steve Norton, and I went home, and about the third patient that walked in my clinic, as I think Cheryl mentioned, told me that she had a migraine in her chest. Have you ever had a patient come in and tell you that? I have a migraine in my chest. And this was about 9 months after she'd had breast cancer treatment. And the first thing that we learned in lymphedema school way back then was that lymphedema didn't hurt. So then I was confused, and I thought, well, maybe there's something else going on, and the doctors assured me that she really just had breast edema. And one of her doctors even told her, well, now your shirts will be a little bit more, fluffed up at the top. That didn't make her very happy. But so I became really concerned about these patients with breast edema because no one was talking about it and no one was paying attention to it. And like I said earlier, I was a design major, and so I decided that something needed to be done for this. And so I happened to live in Burlington, Vermont, which is an interesting small place, and I met the woman who invented the first jog bra. Her name is Lisa Lindahl, and they live there, and that's where the whole jog bra was invented. And I ended up having lunch with her, and I told her the plight of the lymphedema patient and that there just was no product out there that would do chest compression. We had all kinds of things for arms, but we had nothing for the chest. And so she actually came out of retirement, and that's how we ended up creating the Belize bra. So trunk compression is kind of interesting, and breast compression is interesting because we talk about the millimeters of pressure that everybody needs. But for a breast, it's not that much. In fact, a long time ago, I was talking to one of the designers for one of the major brand companies, and she said, well, we did some research, and the patients start to feel a reduction in breathing capacity at 16 millimeters of pressure around their chest wall. That's interesting. That's very low. And so when we were designing the product, we were looking for something that lifted the breast, pulled it into the chest, but didn't restrict the chest wall and didn't restrict the breathing. So that's why we brought it down low enough to the rib cage that it wouldn't hit right around the rib cage. So patients need to be able to tolerate the pressure, and they need to be able to get it on and off easily. So when we were developing it, we hired some bra designers, and they said, well, you can't have hooks up the back and zippers up the front. They just don't do that. And I said, why not? And so we actually did do that, and so that's helpful for helping patients get it on. So when we think about different chest compression products, I think we've got to think about, again, what can that patient tolerate? What can they get on? What's going to work for them? So this patient was told for 3 years when she came to me that she did not have chest wall edema. But she does, and you can see it on the side of her chest wall. But the other thing she had was a fungal infection going down the middle of her back, right here. So we tried to clear that up as well. But this lady couldn't really see herself from the back, but look at the bulge that she's got there. We ended up having a custom-made garment for her because there wasn't any particular bra that was going to help. And what she really wanted was reconstruction, and what she really, really wanted was for this reconstructed side to look like this one. So that's a challenge for any surgeon, and that's a lot of tissue to put there. So all post-breast cancer healing is not the same. It's just not created equal because there's a different place on the breast that they're treated. There's different tissues that they pass through. The radiation can have some effect. The node dissection can have some effect. The scar tissue can be variable. Patients' anatomy and physiology is different in terms of how they respond to this. And so there's just a whole bunch of factors going on with these patients that make their breast edema bad. And breast edema has been a huge concern of mine for over 20 years now. And it really affects patients' lives. It's really hard because it's very painful, and it's often hard to get rid of it. And so I'm really fascinated with some of the work that you all are doing here that looks at the drainage patterns for these patients, and I'm really looking forward to more information as that comes about. Symptoms, of course, and this is from Verbelen, are the orange, heaviness, redness, breast pain, skin thickening, the hyperpigmented pores. from her article, she talks about the testing is mammography, moisture meters, the questionnaires we can measure with a tape measure. But honestly, in all the years that I've been doing this, I've never had an insurance company come back to me and say, well, you didn't measure that in such a way. So the other thing I want us all to think about is that we have skilled hands. We can feel it, we can see it, the patient can feel it, they can see it. And when I describe it in my notes, I've never once been questioned about it. So as much as we want to be able to measure it and then define change, that's wonderful, and that's going to help our literature. But in the meantime, please trust your hands because they are good. I think it's also interesting that 52% of, she noted that 52% of patients have breast edema prior to their radiation therapy, but that, and 47% had it 12 months out. So here's what it looks like, and I'm sure that you all have seen this. This patient had some implants removed because she had a chronic infection and ended up with, well, she has it on both sides, but she's got some more on this side. This is a patient with a little bit of lymphedema going on, and she's got implants as well. Here's her on her edema on the side, but she also had, she's got post-thrombotic syndrome, so she actually had a thrombus. And then this picture right here was actually in Verbalen's article. When I pulled it up, my picture was in her article, so that was kind of interesting. And then there's the scars that we see. And these are some of the pressures. This is from Dr. Pillar in Australia, and these are just some of the pressures that he measured going on in patients' bras. So that's something to think about, especially as we are trying to move fluid into either the supraclavicular area or into the axillary area, and what the patients are living with. And patients need more than one. Back to the toolbox. So first thing is get rid of the tourniquet around these patients. So you're going to look for some kind of a product that doesn't create a tourniquet around their chest wall. In the bra that we designed, we were looking for something that came down lower. We separated the inner bra from the outer bra so that it didn't create a tourniquet effect. And we have a lot of from 32 to 50 in band sizes, because I think that my intention was to create something that was more of a short stretch, custom type, this closest custom as we could get. But there, oh, and then, so here's a patient with radiation. So during radiation, she was having a lot of swelling into her armpit and her arm. So we put her in one, so radiation is one use for it. Here is a patient with truncal edema, and some of the things that we do to help make it more custom is you'll notice that we undid those two hooks down there. So that's a possibility in terms of creating something that works for a patient. Here's a patient with migrating implants. They're going sideways, but look at how good she was when we could get rid of that side swelling. And then there's lots of other different products out there, and that we're grateful for because it helps our patients and it helps us manage them. Lots of different shapes and sizes of textured garments. This is just another example of it. And of course, I hope we've all made these in the past. Sometimes I'll start with that. There's also, do you guys know about the cherry pit pack right here? Does anybody know about the cherry pit pack? For people who have woody fibrosis, this was developed by Karen Ashforth, and she actually uses cherry pits in there too. It's very aggressive, so you gotta be careful with who you use it on, but. Edema wear, is anybody familiar with edema wear? Another option, so this is a slide from Susie Eman, and she takes a piece of edema wear, the largest one, cuts it in half, sews it together, and creates this tank top for patients sometimes, and then she'll put a bra over the tank top sometimes, or she can just, make a hole for one, but back to the texture on the skin helps to soften that. Lots of different shapes of chipped foam. Now, I don't want people to think that if they name the pad, the latissimus pad or something else, that you can't use it. Really what you're looking for is the shape that you're trying to cover, and you're looking at those different pads and trying to cover the shape that you have. My very favorite one that I use on a fairly regular basis is this one right here, which is a lumpectomy pad, but I use it for my total knee replacement patients because it fits right over the total knee and wraps around the back, and I can put Tubi grip over it, and the patients get a real reduction in fibrosis after that. So here's a post-operative pad that we came up with. I did this with Dr. David Craig, who also lives in Burlington, Vermont, and is a friend of mine. He was the first physician out there to actually use sentinel node biopsy for staging cancer for breast cancer patients. He adapted that from melanoma. And so we wanted something that would get up into the axilla after surgery to reduce the amount of drainage that the patients were having and apply some compression up there. So we came up with this particular pad. Then there's different kinds of custom ones. So for patients who are having a lot of radiation, or for patients that need more fibrosis control around the trunk, there's different custom products that we can make, or that they can make, and they can put different binders over the top of them to increase that pressure. Again, more options for patients if they need more trunk coverage. And here is another picture of a patient who the therapist decided to use Coban on. Now, the Coban has to be cut off. You can leave it on for several days at a time, but apparently the Compre 2 can be taken off and then put back on again, but you can get, if you really had someone who really needed a very firm, semi-rigid, more bandaging approach to that, that would be something that they could use. And then this is sometimes what patients come in with. This patient self-treated herself, came in. This is a Nylatex strap, and she had terrible breast edema on the right side that was very bothersome for her, and a seroma that wouldn't go away for over a year that was quite painful on the right breast. And we tried different types of bras, and it impaired anything. She didn't ever wear any bra, so she couldn't tolerate anything around. She decided somehow that using the Nylatex strap would put the pressure on the breast but not go around her rib cage so much. So she actually came in with this as her solution. So I thought that was kind of interesting, and you just never know what a patient's going to come up with. Scars. Scars are a real problem for patients, and I think we need to pay closer attention to those, and I could talk about that for another whole day. But in the patients who have had radiation, obviously the remodeling phase goes longer, and we can be addressing that. And sometimes it's a little 2 steps forward and a little 1 step back, but we can be changing that. And keeping track of their range of motion is really helpful, because that also can go down over time over the next 6 months to a year. Modalities that we can use can be very helpful. I use low-level laser. I use the RianCorp laser. That's a small one, and it's also FDA cleared in the United States for patients. But when a patient comes in with fibrosis and pitting in the breast like this patient had tremendous pain. She's actually a nurse, and she got lost in the COVID crisis and didn't do much self-care and never really got sent on, so it went on for quite a long time. I've also done some dry needling for patients, but not into an implant, of course, but for muscles that maybe are tight, that could be impairing some of the lymphatic drainage. So these are some of the qualities about low-level laser, which can be really helpful, and I know that they use it quite often in Australia. And the middle picture there of me, I actually have 4 of them at my clinic, so I'm often walking around with 2 of them. And so I can do twice as much if I have 2 lasers in my hand, so that makes it a little faster for my patients. And there's just 5 treatments later how much change we had in her tissue texture. Now, I was doing other things too. I was doing MLD, she was wearing compression, she was also using a chip pad at night, but just in 5 treatments, we made a really significant change in that breast tissue. Using a reflex hammer, that's one of my other little tricks if you've ever seen me talk before, but I love to use the reflex hammer because it can grab just a little bit of tissue, and for a lot of patients it's really tender to get in there and push with your finger. It's too big and it's too thick. So if I use my little reflex hammer, I can get in and wiggle, wiggle, wiggle and get a whole bunch of little dots that then connect, and the whole thing just starts to get softer. So don't be afraid to look around your clinic and use some of the different soft tissue tools that you might have used in the past. Pardon me? I'm doing this on some cording. And also some scar tissue because she had more axillary scarring. So care of your upper extremity garment. I got this from the Lymphedema blog. And I think the big thing is to be careful when you wash it and not use things with oil. And finally, I just want to say thank you. And that's my lake picture. I know I'm competing a little bit with Drew because he's got his picture in Maine. But this is truly Lake Champlain, and I live 15 minutes from it. And my husband and I, our favorite thing to do is bike around it. Thank you very much for your time today.